Now we move on to organogenesis. So we're moving from gastrulation and moving into organogenesis, where we're going to see the formation of body organs and systems. So remember that the first 8 weeks, we're in the embryonic period. I think of this as kind of setting the body plan. You have rudimentary structures, you know where things are going to go, and then the fetal period is the rapid growth. This is where we're really establishing the function, the functionality, if you will, of the body structures. This is a nice image to kind of show you that idea of, this is at week 5. Do we kind of have a game plan? Yes, we see where the pharynx is, we see the thyroid, we see we have a tube, which is the esophagus, we see we have a trachea, we have the beginning bulbs of right and left lungs, we have the stomach, we have the pancreas, we have the liver, we have the large and the small intestines, right? So we've kind of set the body plan up, right? Now we have to fine tune all of these organs and grow them to their functional size. Feel free to look at these tables in the book. I'm not going to ask you to tell me the difference between all of these different timetables. Sometimes it's just fun to look. So, when is ossification beginning? When are we creating bone? It's pretty early, right? So we've got the body systems present, at least in some sort of rudimentary form. We have our cardiovascular system, which is fully functioning. The blood is being pumped, the heart is present, right? So then as we move through these, you can see by week 12, you're eventually going to start to be able to see sex differentiation. By about month 4, you can see that parts of the brain are becoming prominent, able to blink the eyes. There's a sucking motion of the lips, so our nerves and muscles are connected, right? We see kidneys developing. We see most of our bones that are distinct. We see joint cavities present. Here at 20 to 30 weeks, or 6 to 7 months, we're going to start seeing myelination, increase in weight. You're going to see temperature regulation starting to happen. Remember, the amniotic fluid was providing kind of the temperature regulation. Now we're going to see the fetus's hypothalamus start to regulate temperature. You're going to see distal limb bones begin to ossify. You're going to see bone marrows become the sole site of blood cell formation. Testes are going to reach the scrotum. So kind of last minute touches that we have to, or milestones that we have to get through before we're born, right? So if you kind of wanted to just summarize the difference between embryonic and fetal, you can see here by week 8, we kind of have the body plan, right? Bones have begun to ossify. We've got skeletal muscles. Lungs and digestive organs have their final shape. We've got blood delivery to and from the placenta. We're going to start seeing the heart and the liver on the ventral surface. And then through the fetal period, this is where we're just going to grow the body structures to their full functional state. I want to come back and talk about fetal circulation. I know we talked about this in cardiovascular, but I want to talk about some of these modifications that exist in the embryo and the fetus, specifically the umbilical arteries and veins, and then the 3 vascular shunts. So they mention here that they should be occluded or closed at birth. So the shunts are basically openings or passageways between various structures. So let's talk about these vascular shunts. The first vascular shunt we have is called the ductus venosus. This bypasses the liver. So it goes from the umbilical vein through the ductus venosus to the inferior vena cava. So something to remember is that vein means going towards the heart and artery means away. So the umbilical vein here is bringing oxygenated blood from mom, right? So oxygenated blood from mom to the fetal heart. And then the umbilical artery would be carrying any waste product back through the umbilical cord, right, into mom's circulation for mom to dispose of. 2, we have a foraminal valve. This is the opening between the interatrial septum. So remember, you have your right atrium and your left atrium, and you have your right ventricle and your left ventricle. So coming into the right atrium, it's going to be your umbilical vein, right? And that's going to dump into the right atrium via the inferior vena cava. And then in between these two, the right atrium and the left atrium, you have an opening. That's the foramen ovale. You have oxygenated blood coming in the umbilical vein, and then we're just going to bypass going through the lungs and just dump the oxygenated blood into the left atrium. So then this third shunt is the ductus arteriosus. So this also bypasses the pulmonary circulation. So you do not have pulmonary trunk out to lungs. You go pulmonary trunk straight to aorta, because remember, the lungs are not functioning yet. So if you're breathing, the lungs are doing gas exchange. But in fetal circulation, what's happening? You're exchanging oxygen and CO2 via the placenta or via mom, right? So the lungs aren't fully formed yet. They're not capable of doing gas exchange, so there's no point in shunting blood specifically out to the lung capillaries to exchange gases. Let's follow this blood flow. So we're here at the placenta. This is high oxygen. This is coming from mom. We're traveling through this structure, which is the umbilical cord. Then we make it to the next structure. This is the umbilical vein. So this is highly oxygenated blood going towards the heart, so vein towards the heart. So then we're in the umbilical vein. Some blood's going to go into the liver because the liver has to grow, so it needs nutrients to be able to grow, right? But some of the blood is going to be shunted through the ductus venosus, and that's going to dump the blood into the inferior vena cava. So that's what they're trying to show you here in purple. So they're saying the deoxygenated blood from the growing fetus and the oxygenated blood coming from mom are going to mix right here, but this is still moderately oxygenated. So it's not depleted, it's just a mix of deoxygenated and oxygenated. That from inferior vena cava is going to go into the right atrium, right? And one of the things that can happen is we can shunt the blood over into the left atrium because we have the foramen ovale. So the foramen ovale is that shunt between the right and the left atrium. Ductus venosus is the shunt between the umbilical vein to the inferior vena cava, bypassing the liver. We also have a shunt up here, the ductus arteriosus, which allows for blood to be shunted between the pulmonary trunk and the aorta. So basically any blood that happens to be in the pulmonary trunk, we don't need to go out to the lungs, so we can shunt it to the aorta. You can also see here the umbilical arteries. So once we kind of process through the blood through this through the fetal cardiovascular system, you're then going to have umbilical arteries, which are carrying the deoxygenated blood. In this case, it says low oxygenated blood, right? And sending it back to the placenta to be exchanged for oxygenated. So basically what's going to happen, what's the naming structure here from the time that we're a fetus, so we're still in utero, yeah, to the time that we're actually born. So we do not want that shunt anymore, right? We want the foramen ovale to go away because we want to be able to use our lungs to exchange gas because we don't have mom's placenta anymore, right? So the foramen ovale is going to become the fossa ovalis. The shunt between the pulmonary trunk and the aorta is going to close, and it's going to become a ligamentum arteriosum. And then the ductus venosus is going to become the ligamentum venosum. So we do not want this part here. We don't have an umbilical vein anymore. We don't need a shunt. We don't need to bypass the liver and jump into the inferior vena cava. So because those structures are gone, we no longer need that shunt. So I know this is a little confusing. What I would know is know the names, specifically this one. This one can be a problem because sometimes the foramen ovale doesn't close at birth. So sometimes we have some fluid that's bypassing some deoxygenated blood that's passing from the right side of the heart into the left side of the heart, and then that can cause problems, right? Low oxygenation. So sometimes that hole will close and sometimes it won't. Sometimes they'll wait a couple of months and then eventually it'll fuse on its own. So I would know the basic structures, what they are in the fetus, what they are in the newborn, and then I'd make sure that I understand veins and arteries, that I understand umbilical veins are highly oxygenated, and that the umbilical arteries are the moderately or low oxygenated blood returning back to the placenta. Let's talk about some of the anatomical changes that are going to happen during pregnancy. So remember, we have high levels of estrogen and high levels of progesterone. So basically your reproductive organs are going to become engorged with blood. Remember, we're opening up the endometrial tissue. We have pools of mom's blood, right? There's also something called Chadwick's sign, where the vagina can turn kind of a purplish color, and you can also see the areola of the breast darken. This is all due to increased female hormones. You can also see pigmentation of facial skin. Sometimes people call it, you'll have a specific pattern, and people call it pregnancy mask. But something to keep in mind is that your uterus is expanding. It's going to occupy the majority of your abdominal cavity as you progress through fetal development. This image is showing you the relative normal size of the uterus, how it's expanding as the fetus is growing, and that we can see here at 9 months, the fundus, or the rounded part of the uterus, is basically underneath the xiphoid process. So you can imagine that if you're gaining anywhere between, some people can gain up to 40 pounds, right? If you're gaining between 10 and 40 pounds, with an average being about 28 pounds, that this is going to change your center of gravity. We've seen pregnant women walk, right? They waddle a little bit, and then sometimes they can develop the sway back, right? That's the lordosis. So basically you're arching your back more so that you can distribute your body weight so that you don't fall forward. There's also something called relaxin. Relaxin is being produced by pregnant women, especially towards the end of the pregnancy. You're going to see that causes the ligaments in the pelvis to become looser, and it causes the pubic symphysis to relax. Basically, in order to make it easier to push the fetus from the pelvic cavity through the vaginal canal. Good nutrition is vital. This is why we're monitoring diet, right? You need to add about 300 calories a day. You also need to make sure that you have enough calcium. Basically, if you're building a complete skeletal system, you need to have adequate calcium. If you don't have adequate calcium, the calcium will be leached from your bones in order to supply it to your growing fetus. Multivitamins, specifically folic acid. So if you remember earlier, we talked about notochord and we talked about neural tube just briefly. Well, that's basically what's going to start the formation of the brain and the spinal cord. You have to have folic acid. If you do not have enough folic acid in your diet during this developmental stage of the brain and spinal cord, the fetus is going to have neurological problems. There are a few more placental hormones. I'm just going to mention a few of these. As we get closer to the end of pregnancy, we're going to have HPL and HCS. You can look at the root here, lacto, mammo. That probably already gives you a clue that as we get closer to delivery, we're going to see a maturation of the breast tissue, and particularly the glands that are going to be producing milk, right? We will come back and talk about prolactin and oxytocin. These hormones also trigger glucose sparing. So mom's going to use fat as energy, and we're going to save the glucose for the fetus. Another thing you can imagine is we need to have increased maternal metabolism. Ooh, say that fast, right? So this HCT, human chorionic thyrotropin, it's like a T3 or T4. It's going to increase the metabolism. And you can see how this would be useful because mom needs to consume food. It needs to be metabolized quickly so that it can pass through the placenta umbilical vein into the growing fetus. Another thing that you're going to see is there's going to be high levels of cortisol. So I'm just mentioning this because high levels of cortisol are what they think is going to trigger the final stages of lung development. So I think it's important to know that. Also, is this going to be a really stressful event, right? Childbirth is probably going to be pretty stressful. Parathyroid hormone. So remember, parathyroid is if you have low calcium levels, and then you need vitamin D in order to absorb, right, for the absorption of calcium. So you're going to have to make sure you have high levels of vitamin D. You have to have, or you will have high levels of parathyroid hormone just in case your calcium dips low. But again, we have to be careful here because we could deplete all of mom's calcium in her bones and you could have brittle bones because you're going to make the fetal skeleton, right? That's going to happen one way or the other. So we'll steal it from mom. We should acknowledge some of the physiological changes that are going to happen to mom. So in the GI tract, gastrointestinal, right, we're going to have morning sickness. This is due to the elevated levels of HCG, estrogen, and progesterone. We're not used to these high levels of these hormones. So they can make us feel nauseous, right, nauseated, sick. There's also heartburn and constipation. They're very common in the maternal or mom's urinary system. We have increased urine production because now we've got fetal waste that we have to deal with. Also, our metabolism is speeding up. So if we speed up our metabolism, we're going to have more waste. Also think about where the uterus is sitting and how sometimes that could press on the bladder. And so this can lead to leakage or incontinence, right? So if you remember the uterus was sitting here and the bladder's kind of about there. So as the uterus grows and we're putting more and more weight on the bladder, that's going to lead to some leakage. And the list goes on. Respiratory system. So the estrogens can cause swelling, stuffiness in the nose, right? Difficult breathing. Also, imagine if the uterus and the fetus make it to the xiphoid process. It's very likely you could have, a very active fetus, and they could have a foot that's constantly pushing your diaphragm. Right? Remember your diaphragm? We haven't really talked about respiratory, but this controls inhale and exhale and breathing. Cardiovascular system changes. So we're going to increase our blood volume quite a bit, 25 to 40%. Cardiac output is going to rise. We're going to start moving the blood faster, right? We've got to propel this volume around the body. The venous return from the lower limbs may be impaired, and that can lead to varicose veins. So basically super high pressure, and that because of all of the extra weight or the extra fluid, it's putting more pressure on the blood as it's returning from the lower limbs. So you might have swelling, pooling of blood. You could have capillaries that become dysfunctional and cause varicose veins. There are several factors that can cause severe abnormalities or even fetal death. This term teratogens, terato means monster. So alcohol, there is no barrier here. Remember, we're going from the placenta directly into the umbilical vein and then directly into the fetal circulation. There is no blood-brain barrier. There is no placental, fetus barrier, right? So alcohol is a chemical. And I guess we could say this for all of them, nicotine, drugs, viral infections. All of these chemicals could disrupt the signaling events that happen as the fetus is growing and developing. So if it's a chemical structure that happens to mimic a normal one in the body, maybe it could bind to a receptor, it could stop cells from forming the exact structures or in the exact location. So usually with alcohol, you see low birth weight, low height, basically it's kind of disrupting the normal system is probably the best way I'd think about it. Nicotine basically causes vasoconstriction. And you'll also see when people are smoking, it's not just the nicotine, there's other chemicals that are in the tobacco, right? So vasoconstriction is one issue, and then you can also have too much carbon dioxide bound to the hemoglobin, and hemoglobin normally carries oxygen. So basically you see low oxygenation, let me get it out, low oxygenation in the fetus if mom is smoking. Another dangerous complication of pregnancy we need to talk about is preeclampsia. This can lead to eclampsia. Basically, something's happening with the placenta. It's not working properly, and that the oxygen levels are decreased, right? So the fetus is basically hypoxic, right? Low oxygen levels. With the mother, we see edema or swelling, we see high blood pressure, and we see proteins in the urine. This is one of the most common causes of premature birth. Oh, let me get it out. Premature birth. Some of the complications, they can have learning disabilities, epilepsy, cerebral palsy, there could be hearing, there could be vision problems. So it's something that we really do need to pay attention to. We're not sure exactly what the causes are of preeclampsia. We think it might be genetic. It could be nutrition. It could be having high blood pressure before pregnancy even starts. And the problem is this affects, 1 out of 10 pregnant women. So it's something that we do need to think about and pay attention to if we want to have a healthy newborn. This word drives me crazy. Parturition. I almost feel like I have to say it slow. Parturition. This is the culmination of pregnancy, basically giving birth. I think it means something like bring birth forward or something crazy like that. Labor. So most of us have heard of the term she's in labor. This is a series of events that are going to expel the infant from the uterus, and they make it sound so enjoyable, right? Expel, get it out. Let's look at this flow chart. So we see estrogen here. We have high levels of estrogen late in pregnancy. These come from the placenta. So the placenta here is making estrogen, and that induces oxytocin receptors on the uterus muscle. So here on the uterus, we're going to have a receptor, and guess what? We just start making more of them. Okay, we have two things happening. We have fetus oxytocin, and then we have maternal oxytocin. So let's do maternal first. So mom's oxytocin is going to come down here and bind to these receptors, and it's going to stimulate uterine contractions. The fetus oxytocin, so baby oxytocin, is going to tell the placenta to release prostaglandins. Those prostaglandins are going to cause more contractions. So we got kind of double contractions. We got prostaglandins, and then we've got oxytocin. Baby's head hits the cervix, and this sends a positive feedback message, release more oxytocin. So basically we have more and more contractions until the baby is removed or ejected or evicted from the uterus. Something to kind of keep in mind is that we do have something called pitocin, which is artificial oxytocin. So if you're not making enough oxytocin to have strong enough contractions to push the baby out of the uterus, we can give you the artificial version. In the last few weeks, we're going to see estrogen levels reach the highest level. We're going to see fetal secretions of cortisol start to stimulate the placenta to make more estrogen. And remember that estrogen is what's causing oxytocin receptors. So we have kind of a feedback there. And then you're also going to see this surfactant protein A. This is going to be excreted from the fetal lungs, and it also helps soften the cervix. Basically, to me, this surfactant is like a check. It's like saying the lungs are ready. We're ready. We're ready to breathe on our own. Go ahead and soften the cervix and start this whole birthing process. What else does this increased estrogen do? So it produces the oxytocin receptors. It causes the formation of gap junctions between the uterine smooth muscle walls. Why do we need gap junctions? So that they can all contract at the same time. We saw these gap junctions when we talked about cardiac muscle. The other thing that the increased estrogen can do is antagonize the calming effects of progesterone. Remember, progesterone was supposed to keep everything calm, so that we didn't eject the fetus or the embryo from the uterus. So this increased estrogen kind of masks the calming effects of the progesterone, and that's where we start having these many little contractions in the uterus. Sometimes this is called false labor. So usually the high levels of estrogen causing the progesterone to stop its calming effect can lead to these kind of mini contractions. We're not really in labor yet. It's not full-blown labor, so sometimes they call it false labor. We know that fetal oxytocin causes the placenta to make prostaglandins, which causes contraction. So we just saw that on the last few slides. So oxytocin and prostaglandins are both powerful muscle stimulants, muscle contraction stimulants. You're going to see that the cervix is going to start descending or descension, right? It's going to widen as the baby's head is pressing on it. Maternal, emotional, and physical stress. It activates the hypothalamus. It causes oxytocin to be released from the posterior pituitary, and we saw that positive feedback mechanism on the last slide. Now we move into the dilation stage. So all of that was the initiation, kind of setting the stage. Dilation is where we're going to see weak contractions. We're going to see the cervix starting to efface and dilate. So I'll show you the face means thinning. And then dilate means get larger, right? The amnion is going to rupture. So water breaking, that's your amniotic fluid coming out, right? You're going to see that the head of the fetus is going to enter the true pelvis. This stage can last for 6 to 12 hours. Here's a nice visual representation. So this is dilation early stage. So here's the cervix. It was touching, right? But the baby's head is pushing. And so you're going to see the effacement, right? The lightening and the widening of the cervix. And you can also see that the baby's head is pressing down on the anal canal. So any feces that happen to be in here is going to get expelled. Also, what's happening to the bladder here, right? If there's any urine in the bladder, that can be expelled as well. We're basically going to smush everything to get the baby's head from the uterus into the vagina and then out. Here's another image to show you late dilation. So again, you can see we're really pushing these structures to their limit on the side. And then we can see here and here, that's a big gap from where the cervix used to be. So finally we get to the expulsion stage. So when you're having very strong contractions every 2 or 3 minutes and they last about a minute long, the urge to push increases. Crowning occurs. You're going to see the head extending past the vulva. You're going to see the delivery of the infant. Something called an episiotomy, I'll show you on the next page, but basically an incision is made to widen the vaginal orifice. So here's the image. We can see the baby's head crowning. We can see that we've just pushed all these structures off to the side. And sometimes if the vaginal opening isn't large enough, they can actually cut further down from the vagina into the perineum. And so that would be the episiotomy. I've been told that they don't like to cut as much as they like to just let it kind of tear if it's going to tear on its own. That a tear will happen along the collagen lines, if you remember collagen or cleavage lines. So basically, if a tear is going to happen, it'll happen within the collagen lines. If we cut, we're kind of going across the grain, and that takes a lot longer to heal. So some of the new wisdom is to just let it happen if it's going to happen. Now we get to the placental stage. So we're still having strong contractions. We're going to have the placenta that's detached from the uterine body, and we're going to see the afterbirth, or the placenta and the membranes, occur. So the placental fragments must be removed to prevent bleeding. Another thing to think about is that all of these placental membranes, they come from the embryo, right? So it would be bad to leave these embryo membranes. They're not you, right? What's going to happen? What's your immune system going to do? It's going to try to break it down, right? It can cause inflammation. It can cause sepsis too, right? You can see here the placenta is detaching. So you can see that material, that extra embryonic membrane material, is being pulled away from the lining of the uterus, and along with the umbilical cord leading to the umbilical veins, right, and the capillaries. So once the fetus is born, we now have an infant, and it has to adjust to these outside uterine life. Obviously, this is a shock to the baby. The lungs have to start working and exchanging gas, and we see here that we assess the physical status of the newborn with an APGAR score. So this is heart rate, muscle tone, respiration, reflexes, and color. So anything between an 8 and a 10 means that you have a healthy baby. I like to talk about the first breath because this idea is going to come up in chapter 22. So in chapter 22, respiration, we're going to talk about the fact that if you have increased CO2 in your blood, that's going to make your blood acidic, and we don't want that. If you remember, we talked about the buffer system that your blood has way back in 201, but we're going to come back to it. So the increase in carbon dioxide, so basically think about holding your breath, right? That increase in carbon dioxide, because remember, you're supposed to inhale oxygen and you're supposed to exhale CO2. So what happens if you hold your breath? You have an increase in CO2. So that increase in CO2 is going to cause your blood to become acidic, and that triggers your respiratory control centers in your brainstem. So this is going to trigger the infant to take that first breath. And remember, this is going to be really hard for them. They've been in this uterine environment. They've had amniotic fluid. Their lungs are not open, if you will. They're kind of collapsed because there's no air in them. We were getting all of our nutrients from mom via the placenta, right? Their airways are tiny. There's also this chemical, this kind of detergent, surfactant, and this is made by the lungs. Again, we'll talk about it in chapter 22. And it helps reduce surface tension. That means stick together. So it stops your lungs from sticking together. Probably the best way that I think of this is if you've ever held a contact in your hand, if you've ever had to put a contact in your eye, sometimes the sides will stick together and then you kind of have to roll it to open it up. We don't want that to happen in the lungs, right? We want the lungs to not stick together. We want them to spread apart so that they can take in as much air. And that'll make more sense as we look at the alveolar structures in chapter 22. So in the very beginning, the respiratory rate is about 45 breaths per minute the first 2 weeks, and then it kind of declines to a normal level. There's also this unstable period. So about 6 to 8 hours after birth, they're going to alternate between activity and sleep. Vital signs might be a little bit irregular during this time. The baby's going to gag as it's regurgitating the mucus and the debris. They usually will clean out the mouth, right? They'll suction it as soon as the baby comes out, but some of it might have been swallowed, right? So usually stabilizes with these waking periods that occur every 3 to 4 hours. So this is why they check on the baby a lot right after it's born, right? They're in there every couple of hours, maybe every hour on the hour, and you don't get any sleep. Of course, we have to come back to our favorite topic of hormones. Let's talk about lactation. So remember that we need to produce milk in the mammary glands. Remember, towards the end of pregnancy, we have those estrogens, which cause the increase in oxytocin receptors, right? That is also stimulating your mammary glands. Also, progesterone, lactogen, if you remember that, stimulates the hypothalamus to release prolactin releasing factor. Anterior pituitary releases prolactin. Oxytocin causes the milk letdown reflex. So they talk about these prolactin releasing factors. We also talked about dopamine when we talked about prolactin, right? So we said there was something called prolactin inhibiting hormone, and that if prolactin inhibiting hormone was low, then that would allow for the release of prolactin. During the first 2 to 3 days, something called colostrum is secreted from the mammary glands. It's yellowish. It's rich in vitamin A and proteins and minerals, and then these IgA antibodies. So these are the antibodies that are going to protect the infant's gut from any possible bacterial infection. Remember, the infant's immune system has not fully engaged yet, so we're relying on mom's breast milk to provide those passive antibodies for the infant. Also, it's lower in fat in the very beginning. So lower in fat, higher in vitamin A's and proteins and antibodies. And then eventually we have this kind of true milk production after the first 2 to 3 days. And that the suckling infant is going to promote positive feedback mechanisms. Eventually, prolactin is going to decrease, and then what's going to drive the release of milk is stimulation of the nipple. This figure, they're just trying to show you that the anterior pituitary is going to release prolactin that causes increased milk production. And remember, the oxytocin from the posterior pituitary is going to stimulate the breast to contract so that we can release the milk through the ducts of the nipples. And then eventually, the mechanoreceptors at the nipple are going to send messages back to the hypothalamus and cause this positive feedback system. Eventually, we're going to see the stimulation of the mechanoreceptors driving the milk production and letdown, and you will eventually see prolactin start to decrease. What are the advantages of breast milk? Well, they are going to have fats eventually. The first 2 or 3 days, they don't have as much, but they are going to have some. They're going to have iron, right? Hopefully we remember why we need iron. Red blood cells? Yeah, okay. Amino acids, they're already broken down. So it's not necessarily big chunks of protein. They're more easily broken down into the individual amino acids, which are more easily metabolized in the infant compared to cow's milk, which has large proteins that need to have enzymes to break them down before they can be absorbed in the infant. There's going to be chemicals like antibodies. If you remember that complement protein, that's the one that pokes holes in bacteria. Pokes holes, right? Lysozymes, those have digestive enzymes inside of them that can digest particles that aren't needed anymore, right? And then interferon, that was the one that did the cell-to-cell signaling if it was infected. You're also going to see interleukins, you're going to see prostaglandins, and all of those are going to help not have a high inflammatory response. So they're going to kind of keep inflammation at bay. We have a second page of advantages. So it's a natural laxative for the infant. It encourages bacterial colonization in the infant. So 2 things kind of. The infant, as it travels through the vaginal canal, is picking up bacteria. And then the breast milk helps encourage that bacterial colonization for the infant in the large intestines. Remember, there are some bacteria that we need in order to successfully process our food and get the vitamins that we need out of it. Nursing moms, right, more than 6 months can start to lose bone calcium. Women may ovulate when nursing despite the inhibition of GnRH and gonadotropins. So there's kind of this old wives' tale that if you're nursing, you can't get pregnant again. There's lots of people who have gotten pregnant a month or 2 after giving birth. And I just like to make sure we understand that this is not the case because it's not good, right, for bone density in females. It actually takes you almost a year to get your uterus and all of your hormones back to normal levels. So like pre-pregnancy, it takes about a year. So imagine if you've been pregnant for 9 months, maybe 9.5 months, right? And then within a month or 2, you get pregnant again. Your body hasn't had time to adjust from the last pregnancy, and now you're asking it to grow another baby all over again, right? So we also see bone loss occurring because, hopefully you're taking enough calcium, but if you're not, then we can have that leaching from our bones as well. So I think this is the last slide. I'm going to move on and talk about genetics.